Hello and welcome to Voices for Mental Health, the podcast where we engage in real talk about mental illness and share personal experiences from everyday people, mental health experts, and mental health peers. I'm your host, Candace Schoner. Today, we are going to be talking with Dr. Alberto Augsten, the founder of Augsten Consulting. Dr. Augsten has a master's in pharmaceutical sciences, and a concentration in clinical toxicology. He is also certified in forensic drug chemistry and is an expert witness in legal cases. Thank you, Dr. Augsten, for joining us.
Thank you for having me.
Well, can you share with the audience your journey and what inspired you to focus on clinical toxicology and psychopharmaceuticals?
Great question. It's a question I get often, even from my children. It's one of those, what really drives you and takes you on that path. And I think for me, I started off my career heavily in the sciences. I was a chemist before I went into this journey, and I actually worked as a chemist in the downtown area of Miami. And I would spend my afternoons typically having lunch just within downtown Miami. And every Friday, I would typically share a meal with anybody that I would find that was interested in sharing a meal with me who was suffering from homelessness. And it was just something I enjoyed doing. And I kind of realized, what a need there was to, have better access to care for these folks, better access to the community, better access to things that many of us take for granted. And really, that was the trigger, just engaging individuals that had a particular need. And I wasn't even aware of it. And it became something near and dear to my heart.
That's interesting because when it's working with the homeless and helping homeless people, I think, how do they get medication if they have a mental illness?
Yeah, I mean, it's very difficult. And one of the things that we focus on the clinic that I oversee, I oversee a few clinics. One of them is a long-acting injectable clinic for individuals who have serious mental illness. And one of the benefits of the program that we oversee in a very large healthcare system is that 30% of the patients that we service are indigent. They have no insurance. They have very low access to financial means. And we found it to be extremely important, besides the fact that our system is a safety net hospital, to provide a program that allows folks who don't have access to those means to get help. And so the biggest challenge, to your point, is sometimes these folks end up having struggles being able to be in one location for a long period of time. Transportation is an issue. And so we go above and beyond to ensure that we give them that access, whether it's transportation or finding them a safe place to stay in between locations.
Now, since you I can't think of another word, but other than entrenched with the homeless population, did you, and in your research or experiences, find that a lot of people are homeless because of mental illness?
Yeah, great question. When it comes to rates of mental illness amongst those suffering from homelessness, we know the studies tell us that it's higher. I usually reflect on a base of statistics, and I tell individuals who are curious about even schizophrenia, and they'll say, what percentage of the population has schizophrenia? And that percentage is about 1%. But what percentage of the population who's homeless, suffering from homelessness, has schizophrenia? And it's close to 20 to 30%. And that kind of tells you that those who have severe mental illness struggle, number one, getting access to care. And as the disease continues to progress and get worse, it makes it very difficult for them to hold a job, to hold access to their family still. And so many times they end up, having trouble maintaining their homes.
Right. Now, you also have been teaching, I've been a professor of pharmaceutical, and I'm wondering how, and that's been like, I think, the past 15 years, is that correct? That you teach pharmaceutical
That's correct.
toxicology information? So, how has being a teacher influenced the way that you view mental health?
So teaching has been something that's very near and dear to my heart. I'm a professor at Nova Southeastern University for 15 years. It's hard to believe it's been over a decade of teaching. So for me, the ability to teach the young mind is very special. I love to be able to teach. Is something that's near and dear to my heart. And I find that especially those individuals that are early in their journey of education, it's fundamental to be able to have access to those individuals who have the knowledge, have the experience, and we can pass down that wisdom. When it comes to mental health and the impact it may have on the folks that are in current education programs, it's something that is always concerning. We always want to make sure that if there are extreme stressors and there's something going on in your life and it's impacting your ability for education, that professors can be there for you and can understand some of those struggles.
Right, that makes perfectly good sense. I also understand that you have a lot of in-depth experience with working with bipolar 1 disorder patients. So can you share what that actual diagnosis is, first of all?
Yeah, I could share about bipolar 1 disorder. And so a good way to look at bipolar, you're looking at two extremes. And so traditionally, bipolar are individuals who have both possibilities, meaning they have the ability to have experienced depression and also what we classify as manic episodes. And the real distinction is that depression is oftentimes described as anything affecting your sleep, interest, energy, concentration, appetite, even those folks who may have increased thoughts of wanting to harm themselves, like suicide. And then mania is quite the opposite. Usually it's described as having an elevated mood. Oftentimes they have thoughtless behavior. Maybe they engage in activities that's very risky. Some of them may end up experiencing episodes where they're gambling. They can gamble away an entire week worth of their paycheck, perhaps doing things that are things they wouldn't normally do, engaging in risky behavior like having sex with various people unprotected, going on binges, using high amounts of drugs and alcohol. And so the manic episode, it's quite the opposite. And so unfortunately, bipolar disorder means an individual may have experienced both of those things. What's understood, though, is bipolar, for the most part, folks are more often than not in a depressive state than in a manic state.
And so I assume that medication is sort of the number one treatment for someone with bipolar 1 disorder?
Absolutely. And the studies have shown that bipolar disorder can be treated very well. There are medications that we can utilize to treat it. Number one. Number two, we've also shown studies that show treating bipolar disorder efficiently with the right medications can help your patient stay in a particular uh, position that they're not experiencing manic episodes or depressive episodes, but more importantly, keeping them out of the hospital. That's the most important thing, because clearly nobody wants to be hospitalized. But if you do get hospitalized, we know that your baseline may get worse every time you get hospitalized. So that's the most important aspect about treating bipolar disorder.
So I'm curious, why would the baseline change every time that you get admitted to the hospital?
So you have to kind of imagine our brain as having activity that is working at our normal function. And so the way the brain works is the brain has all these nerve terminals and there are neurotransmitters, and a lot of folks listening in are familiar with them: dopamine, norepinephrine, serotonin. And so these neurotransmitters are going around and they're doing their jobs, they're activating things, they're being reuptaked and they're being then degraded and re-released. And that's, I call it, that's a constant train. And so what happens when one is especially manic is that you have a instinctively elevated amount of these neurotransmitters. You could present with all the signs I mentioned, very elevated mood, disorganized. You could even have a period of psychosis, right? So you could be disorganized, you can be thinking things that aren't true, having hallucinations. And then, unfortunately, when that happens, you require hospitalization. And when that state is active, meaning your brain is in the active state of mania, many times a lot of the functions that you normally have can be affected. And so that's your baseline. So maybe when you get out of that episode, your baseline may be affected. And we just know that every time one gets hospitalized, usually when it comes to the way our brain's working, we have decreased impact, meaning our brain is not the same it was as we went in. So we want to reduce those episodes. We want to reduce the impact of hospitalizations on those individuals, and the best way to do that is to be on medication.
Right, thank you for answering that. As far as medication goes, and this is really not really about the medication per se, but am I correct that spring or changes in environment can trigger people with bipolar disorder?
So that's a very great question. And if we have to really look at spring as a time when there's a lot of changes happening in our environment, there's two changes that we really look at. The first being the changes to sunlight, right? Classically, spring's here. We're approaching summer. What's happening? The days are getting longer. There's more sunlight. With more sunlight comes, obviously, there's more impact on the brain, which is a good thing. But for those that have bipolar disorder, you're getting an increased release of dopamine, maybe an increased release of serotonin. And so those things I mentioned are neurotransmitters. When there's an elevation, there's an increased risk of potentially inducing a manic episode. Moreover, during the spring and as we approach summer, what's typically happening? Well, there's more activity, maybe there's more events, especially if you're very young. Maybe there's more parties going on, maybe there's more time outside, maybe there's more time at events. And so those things put increased stressors on the body. And so the bottom line, in my opinion, is spring is great. There's more things to do. It's just being aware of our bodies and seeing, hey, how is this going to affect me? One of the most important things that we could do is get the rest and hydration we need when that is happening.
It sounds like to me, if someone's in a manic state, as you said, and they're very uplifted, is that also a trigger for not taking the medication and feel like, well, I'm fine, I don't need medication anymore?
Very good point. And it's a struggle. And so in bipolar disorder, unlike when we treat just depression by itself, and many folks can probably relate, if you've been depressed or suffering from major depressive disorder, it doesn't feel good. And, we can get our mood is down. We don't feel well. And there's a lot of symptoms. And one of the worst symptoms is a feeling of hopelessness, right? That nothing's going to work and I'm stuck in this hole. Well, when you have bipolar disorder, unlike being depressed, you have experienced elevated mood. You have experienced mania. And in some folks, bipolar disorder, hypomania, meaning a feeling of elation, of well-being, more than just being normal mood. You felt elation. And so those who have bipolar, it's tricky because when you treat them with medications, some medications, if you're reducing your mania, it can make you feel down, and nobody wants to feel that way. And moreover, to your point, when you are manic or even hypomanic, part of the feeling and part of the criteria is you have elevated mood. It feels great. Unfortunately, that feeling of greatness can lead to behavior that's very dangerous. It can lead to behavior that can cause you a lot of damage down the road. So while it feels great, obviously the medication is there to protect you.
What about alcohol? I mean, I take medication. I think probably most of us take medication out there. I assume that alcohol is not good for people that are taking medication for bipolar disorder?
It's a common question, and I think alcohol across the board for anything, right? Especially mental illness. But anything. The bottom line is alcohol works on neurotransmitters in the reward pathway. It works on neurotransmitters in what's called the GABA center. It's a downer, just as the name says, downers bring you down. They dysregulate things. They make things more difficult. So it's well known that alcohol in small quantities, there may be some benefits, maybe like wine, one glass of wine, and there's always an argument back and forth. However, if we're suffering from bipolar disorder or anything related to the categories, it's something we try to stay away from because it acts as a mood dysregulator. It affects our mood, regardless of what we want it to do. It can affect our mood.
Do most people with bipolar disorder need to have their meds supervised? I know several people that actually, and this is why I bring up these questions, that have been diagnosed with bipolar 1 disorder. And I do see them using alcohol to self-medicate, and I do see them going off their medication.
Good question. And, I run a clinic that administers long-acting injectable antipsychotics to treat also schizophrenia and bipolar disorder, as a matter of fact. There is a great benefit to that if adherence is an issue. I would argue that in bipolar disorder, there's plenty of oral regimens that are quite effective. And many times, what we see is if you're on the correct oral regimen, patients see the benefit. And that provides a great deal of motivation for them. And they feel like, great, this medication is working. I feel wonderful. And that's a motivator. They want to stay on it. And if we provide the right education and say, you know what, excess alcohol can be very dangerous, I think that's key. I think education is what's needed to help patients make the right choices.
So in that education, I imagine there's multiple medications for the treatment of bipolar 1 disorder. How long does it take for someone to find, I guess I'm going to call it the right cocktail, because I imagine it's more than one medication, am I correct?
You know, that's probably a major complaint of many individuals who are treated for just about anything when it comes to in the mental health field, depression, bipolar, even schizophrenia, that they go through various regimens and they struggle to find what works. Bipolar disorder is even more difficult. The bottom line, there aren't a lot of regimens that work really well in bipolar disorder. There aren't a lot of things that help treat the depressive symptoms and not make you feel your mood too low. And there's not a lot of things that treat the mania that work well and for a long period of time. So there's not a great deal of options. There are a few that work really well. And once you find it, it's something that once patients start it, they don't want to stop it because it works so well.
Is that because of a lot of drug interactions with other medications that someone may be taking before they've been diagnosed?
No, you bring up a great point. There's plenty of medications that have been used traditionally for bipolar disorder. There's some older medications like lithium, valproic acid. Those have found to be efficacious for treating bipolar disorder. Unfortunately, there's tons of drug interactions, meaning they interact with many things. To your point, the alcohol discussion is definitely not something you want to combine with either of those two agents because of the interaction risk, just because of the interaction risk, not the fact that they depress your mood. And so, yes, that's very challenging. And hence, finding the right medication. You don't need to be on multiple of them. You just have to find the right fit.
I'm going to switch topics here a little bit because I know you're a legal consultant. And I do believe that people on psychopharmaceutical, or my question is, do you believe that people on pharmaceutical medication who commit a crime should be held accountable, or should there be other cause and effect of them committing a crime? Or should they have other ways of being punished, I guess? I can't come up with another word.
Maybe you bring up a really good question. It's something that I get consulted on all the time from both sides, whether it's defense or prosecution. It's very challenging question. And it's something that is heavily discussed in the legal system. There needs to be a variety of experts involved to determine the mental capacity of the individual who committed the crime. There has to be an understanding of the medications the individual is on or not on. And there has to be an understanding of were there potential risks at the time that impacted the regimen. I've had cases of individuals that have actually participated in illegal activity, and they were actually in a manic state. And they were in a manic state that was induced by a regimen that another provider had started them on. And so I was able to testify in a case of such magnitude to kind of shed light that this is a risk. But what I would say, it's a very delicate topic that deserves a lot of attention from various individuals to ascertain the mental capacity of the individual who committed the crime.
Absolutely agree with you on that. How can someone tell if another person, or even within themselves, if they're going to have a depressive state or a manic state? Is there signs?
Good question. I would say it's a it's every patient has their own top symptoms that they focus on. And so if you look at the diagnostic criteria for depression, they focus on a mnemonic called SIG-ECAPS, SIG-ECAPS, so sleep, interest, guilt, energy, concentration, appetite, something called psychomotor, and then suicide. Those are the things that we focus on. Now, the way I would usually educate on these things, I would always tell individuals to identify what are your factors. Like if your main one is sleep, sleep is a great one. It's excellent. Many of us are aware of our sleep patterns. When you're depressed, you have two potentials. You may not sleep, and maybe you have a great deal of guilt on your mind or of trouble focusing, and you can't sleep. And maybe you're the opposite. You're sleeping too much. And the same thing that happens in those who are depressed. There's a key difference here. Usually your energy is way down, very low energy. Now, when we're approaching mania and hypomania, the opposite happens. Our sleep gets less and less. When we're approaching hypomania and mania, individuals may only need 2, maybe 3 hours of sleep, but they're full of energy. So it's a great thing to target. If we notice our sleep is off, it's a great way to say there's something happening here, and I need to talk to my provider to say this is what's going on right now.
Very, very interesting. Do you have any suggestions for patients with bipolar 1 disorder, other than, as you just mentioned, sleep, to lower their risk of impulsive behavior or depressive episodes?
Yeah, I mean, I think knowing these things are crucial. Knowing what affects your body, even from diet, is important. Sleep is a major one. So having your sleep regimen down packed. Regimens are very important in mental health. Having a time we wake up, a time we go to bed, a time we go out to the park, a time we exercise. Exercise is crucial. The foods we eat, the things we do, and the activities we engage with. And then knowing your medications. Knowing if you have bipolar disorder, there are medications out there. There's some great new medications that are very effective, and we're using them, and they have a very low risk of weight gain. Weight gain is a big question that we typically have when we start regimens and we're concerned about it. There's some regimens now that we can use that are very effective, and that risk of weight gain is mitigated. So knowing those things is crucial on your journey to treating your bipolar disorder.
I will say that just talking about to my friends and things about this, weight gain with any medication is always a problem, particularly among, I guess, females more than men who are more self-conscious about that, and we don't want to take medication that's going to cause us to gain weight. But I say if you're in a better mental health state, that's all that really matters. So how can physicians and families work together to create more effective and safer plans for patients that are at high risk for depression, suicidal thoughts?
Yeah. I mean, to me, one of the biggest factors in my journey when I've educated and discussed and talked to groups and done my own presentations is understanding what we're dealing with, understanding that bipolar disorder has the two potential extremes, but then having the education that about 67% of the time, so two-thirds of the time, they're actually in a depressive state. They're in a low mood state. That's majority of the time. And so knowing that, and then understanding how it presents, having conversations is crucial, right? The idea of somebody wanting to harm themselves is something that makes a lot of us not want to touch the topic, but it's the opposite, it's having the discussions. And even it's gender specific, right? Men to men, typically the question we look at each other in the eye and say, "Are you all right?" And the men would be like, "I'm all right." Like it's just a gentle nod and say, "I'm all right," versus "I'm not all right." That opens the door, that tells you, hey, I'm here. I could be a resource for you. Let me know. I want you to know I'm here for you regardless. Whatever it is, I'm always going to be here for you. And letting them know. And I always like to tell my patients when I meet with them and they're coming in for, let's say, a treatment-resistant depression episode. And I always say to them the following: if you are alone on a weekend, if there's ever a moment you're by yourself, and you feel hopeless, you feel that there's no out, I just want you to know that I'm always going to fight to figure out a way to help you. I'm always going to fight that. And so just always remind yourself that we're never going to give up. So while you feel hopeless, let us take that burden for you and know that we're going to keep fighting for you. So just so they know that there's always an opportunity somewhere.
I love that. And I think on that very positive note and helpful note, we're basically out of time. But if someone does want to get a hold of you, do you have a website or are you on social media? Can you give that out to us?
Yeah, I have a website, my last name, Augsten Consulting. You could find me there and you search for me. And, you could find me on a couple areas, and I'm more than happy to help anybody that's seeking some needs there.
Well, thank you very much for your time. We really appreciate it, Dr. Augsten. It's been very informative. I've learned a lot, and I think our audience has too. To those who are listening to this podcast, remember, as Dr. Augsten said, and I do, you are not alone.